Thank you very much. I remember coming to that support group very well. It's one of those great meetings where you sit there and people are there complaining about their doctor, and it's actually you sitting right there. So it was a character building time. I haven't actually been invited to another one yet. I don't know if it was my choice or their choice, but anyway, thank you very much for inviting me to talk tonight. I don't have any videos and any exciting stuff. I'm just a simple medical oncologist. We don't have that sort of exciting day that Steve talks about. I've been given the task of talking about colorectal cancer and some of the new targeted treatments in about half an hour, which will be remarkable if that's achievable. So what I'm hoping to do is just to give an overview of some of the issues that we have seen in the progress in managing colorectal cancer, particularly looking at some of the new targeted treatments. There are a few take-home messages, and the thing that I'll harp on about most is the heterogeneity of the disease. And really what that means is the wide spectrum of disease that we see with metastatic colorectal cancer or even with early colorectal cancer. And one of the key take-home messages is that the disease is quite variable, and what your next door neighbour's brother's friend had is quite different to another patient's, and so the treatment that they're on are quite different. So colorectal cancer is not one disease, there's a wide spectrum of disease. The other very important thing is that we've seen a remarkable amount of progress in how we manage this disease over the last 10 years. I'm also going to spend a bit of time mainly talking about the targeted treatments in patients with metastatic or more advanced disease, and not spending as much time talking about the early stage disease where treatments are a little bit different. We'll touch on some of the newer agents, and these are some of the drug names that we'll talk about. A drug called capecitabine or Xeloda, irinotecan, oxaliplatin, and then looking at some of the new biologic agents, and then a bit of time on some of the liver-directed therapies. That's the message. Heterogeneity of disease. There's a whole spectrum of patients, and what's relevant to one patient is not relevant to the other. And what your doctors will be doing is taking all of the information about your disease, the pathology of the disease, the extent of the disease on imaging, some blood tests, and then also factors about the patient themselves to try and determine what is the most appropriate treatment. And that's one of the reasons why the treatment that Mr. X is getting is quite different to what Mrs. Y will be getting. We've seen some marked progress over the last 10 years, and really what you can see from this was from the first drug that was used in colorectal was used in the 1960s, and from 1960s to 2000 not very much happened in colorectal cancer. And then in 2000 there was the use of a drug called irinotecan or Camtasar, which was really changed the way we treated this disease. For the first time we were starting to see that we were actually making a difference to patient survival. As a result of that, a number of other agents came to the fore, and more recently, since about 2000, a bunch of the new specifically targeted agents were developed. And the reason that those were able to be developed was that some very clever scientists were able to understand what was driving a tumour, what was making the biology of the disease grow, what was making the tumour grow. And so certain drugs were then targeted against those particular proteins or processes. So this is just a schematic representation. As far as response rates were going and survival, things were very bad when you're just using 5-FU on its own, but you can see over the last few years there's been a dramatic improvement in those outcomes. The backbone of treatment for colorectal cancer is still chemotherapy. And the problem with chemotherapy is that how chemotherapy works is that it's selectively targeting rapidly dividing cells. And we know that cancer cells are dividing more than normal cells are. So we get a preferential destruction of cancer cells over normal cells. The other thing that's happening is that cancer cells don't have a good ability to be able to repair themselves. So when we kill a cancer cell, hopefully that cancer cell will stay dead. But the normal cells, although they'll be affected by the chemotherapy, should have mechanisms in place so that they can repair. And that's why, one of the reasons why chemotherapies are given in different cycles, because it allows the normal cells to recover and repair. So chemotherapy is the backbone of treatment, but I'm not really going to talk about that very much because it's not a particularly targeted approach. And one of the ways that one of the things that we need to look at is that chemotherapy is a bit more of a sledgehammer approach, and we're killing a whole lot of normal cells along the way, even though we're having an impact on the disease. And now there are ways that we're trying to look at avoiding that destruction of normal cells and trying to improve the outcomes of just and trying to improve outcomes by specifically affecting the cancer cell. Just to mention, there is a difference between treating people in the early setting or the adjuvant setting, where we think all of the disease has been removed, but there may be a chance that there's some tiny microscopic cells, and we sometimes give people mop-up or insurance treatment. That's quite a different disease that we're treating to patients with more advanced disease, where we're looking at what we can do to slow the disease down and keep it under control for as long as possible. And again, the focus of tonight will be more on patients with more advanced disease. So just to throw a few names around, there's drugs such as Folfox, which is a combination with an agent called oxaliplatin, or Xelox, or Folfiri. Those are the current backbone of chemotherapy agents that we use. The other thing that's starting to happen is, as we control the disease in other areas, sometimes the liver is the main focus where activity is. Now, in some situations, we want to try and do an operation to remove the liver disease, but if we can't do that, there are a bunch of new agents that have been developed to target disease specifically in the liver, and we'll talk about that. The key to all of these developments is the research that's gone on and the clinical trials that have gone on to understand the biology of the disease better. And as you understand the biology of the disease and you know what the particular defects are, or what the particular drivers of tumor growth are, those agents can be selectively targeted. So in 2013, this is the situation. It's complex. We have many choices, many options, and what our job as the oncologist is to take all of those features of the tumor and all of those features of the patient and try and work out how best to schedule and time the different treatments. And we need to take into account the efficacy of the drugs, the side effects and the toxicity of the drug, and also how the patient is tolerating the treatment. And obviously these have some cost implications as well, both for patient and for the community. The first drug I want to talk about is actually a chemotherapy agent, and it's an oral agent. It's a tablet called Xeloda or capecitabine, and I'm seeing some frowns in the crowd about this. But so capecitabine is actually a prodrug, which is a drug that is not active when you swallow it, but I'll show you the mechanism where there's a particular protein that changes that from an inactive drug to an active drug. It's a tablet that people take for 2 weeks out of a 3-week cycle and is generally well tolerated, or although some people do have a difficult time with it, with the main side effects being a rash on the hands and feet and some diarrhea. And we know that this agent is active, it improves patients' outcomes, it improves patient survival, but importantly, it's also designed to try and improve quality of life and symptoms. But obviously this needs to be weighed up against the side effects. And for some patients, the side effects of that agent outweigh the benefit. And that's the importance of your regular assessment with your oncologist, is to try and balance all of those issues. So the way that this drug works is that you swallow the tablet orally, it gets absorbed in your intestine and gets changed by a few chemical processes to a particular drug. And then in the tumor itself, there's a particular protein called thymidine phosphorylase, which converts inactive 5-FU to active 5-FU. And 5-FU is the active protein, is the active agent. Now that protein is found in highest concentration in tumor cells. So it's a very clever way that we can convert an inactive drug to an active drug where the most activity of that drug is where we want it in the tumor cell. So as far as chemotherapy is concerned, there were 3 agents. All of these have shown an improvement in survival. All of these have shown that in some situations they can reduce tumor burden and make doing an operation an easier thing to do. We know that they improve quality of life and do offer some patients a palliative benefit. And we also know that we can now give some of these agents much easier because we've got the development of a whole lot of other supportive factors. So other agents that help with nausea, that help with vomiting, that can help with some of the other side effects of the disease. But the real excitement has come with some of the newer biologics, some of the newer targeted treatments. And so we spent a lot of time, we don't have fancy robots, we have beavers with targets, and that's how targeted therapy was developed in the oncology field. So the first agent I want to talk about is, the first target that I want to talk about is this protein called the epidermal growth factor receptor, or EGFR. Now, what this is a protein that sits on the outside of cancer cells. And when these proteins land on that receptor, it basically does a whole lot of processes within the cell itself, and then it does everything bad for cancer. So if you've got this particular receptor and that protein lands on that receptor, it sets up a whole lot of pathways, but then does everything bad for cancer growth. It makes the tumor mature and get more aggressive. It causes resistance to chemotherapy and radiotherapy, so it makes our treatments less effective. It does this process of angiogenesis, and we'll talk about that in a minute, but basically what that is the development of new blood vessels. So it allows the tumor to spread further. It encourages the tumor to spread, and it also stops this process called apoptosis, which is a process where cancer cells die because they're abnormalities when the body gets rid of those cancer cells. And so this receptor blocks all of those. This receptor stimulates all of these, so essentially does everything bad for the tumor. This has therefore been a very good target, because if we can block this receptor, we'll potentially stop all those other pathways that are being stimulated to allow the tumor to grow. And there are a few ways that you can block it. The one is to put a little protein on the outside of it, which sits on that receptor and stops that little protein from getting on there. And the other way is to turn the process off from the inside. And there are a bunch of drugs that have been looked at to try and block those. There are two agents in this space. The one which is now available in Australia is a drug called cetuximab, or Erbitux, and then there's another agent called panitumumab, which is also been shown to be of benefit but is still awaiting approval in Australia. What we know from this agent is that it can slow down tumour growth in some patients, but it's not in all patients. It's only patients who have the upregulation of that particular protein. And one of the things that subsequent research has found is that it's not just that protein that you need, it's actually this particular protein here called KRAS. Because if that KRAS is on, it doesn't matter what you're doing on the outside. So if you block things on the outside and this is already turned on in the inside, you're not going to have an impact. And that's what we're starting to do now in all our patients, is testing whether they have that particular protein, and if they do, we've got an agent that can block that. I'll call them back. Okay, this is one of the main, this drug is generally well tolerated, but the main side effect of it is an acneiform rash. And there has actually been some research which shows that if you develop the rash, the outcomes are better. So the patient comes in complaining about the rash, and we're going, excellent, you've got the rash. So we've got to try and liaise and make friends over that. The next issue is the role of angiogenesis. And angiogenesis is the process of new blood vessel formation. And basically what tumours do is encourage new blood vessel formation. They secrete a whole lot of proteins, so that's a tumour cell, and it secretes these little proteins which make new blood vessels grow to that tumour. And when those new blood vessels grow to the tumour, it allows the tumour to grow more, it gives it nutrients, and it allows it to get rid of its wastes. But importantly, it also allows the tumour cells to move into those blood vessels and go somewhere else. So this process of angiogenesis is a very effective way for the tumour to allow it to continue to grow and to spread to other places. The interesting thing about angiogenesis is that it doesn't occur normally in the normal cell, in the normal system. The time that angiogenesis occurs is in pregnancy, in the development of the uterus, in wound healing, and in tumour growth. So if we can target angiogenesis, we're potentially only going to be affecting the tumour growth issue, because a lot of those other issues are not applying to individuals. The problem is that it's quite a complex area, and if you block one pathway, another pathway gets upregulated. So it's currently, there's a lot of research trying to balance all of those things out. Now there is a drug called Avastin, which is a drug that's developed to block that particular pathway. Now all of these agents sound very interesting and exciting. It comes back to the same thing that I said in the beginning. It's all about heterogeneity. So these drugs, because they're available, are not necessarily relevant for every patient. And that's what the responsibility of the oncologist is to weigh up all of those factors to determine which patient is most likely to benefit from which drug, or which order of giving the drugs, or which sequence of having the drugs. But generally, these are the most novel agents that we've got in this space. The other area that's of interest is dealing with the liver directly itself. Now, in some situations with metastatic colorectal cancer, most of the focus of the disease is in the liver. And if we can do things that specifically target the disease in the liver, that may be a helpful outcome. Now, obviously, if there's disease in the liver and the lungs and the bone and other areas, targeting the liver is not going to have a major impact. So again, this is only relevant for certain situations. Now, the ideal option, if we can, is to remove liver tumours if it's technically possible surgically. Now, we would have a multidisciplinary meeting, and there's surgeons there, geneticists, pathologists, about 20 people in the meeting, and we would discuss individual cases to see whether or not surgery is the best option or we should be looking at liver-directed treatment. Now, the liver is an interesting organ in that it's one of the only organs in the body that has a dual blood supply. It's getting blood from two places. It gets blood from the portal vein, and the portal vein basically supplies the whole liver, and it also gets blood from the hepatic artery. And the hepatic artery is the artery that supplies almost all of the blood that goes to tumours. So people came up with the concept that if we blocked sections of the hepatic artery, you could potentially starve blood supply to the tumour and effectively target the tumour, but without affecting the rest of the liver, because it will be getting its blood supply, so won't die from not having blood supply through the portal vein. So there were a few strategies developed to do that. And the first strategy was just to block the vessel. So block it, starve it of oxygen, and the cells would die. Subsequent research has shown, well, we can do something even more fancy than that, and that is to add little beads of radiation. So what's happened now is we do this process called SIRT, or selective internal radiotherapy, where we get into that hepatic artery, block the artery, but also deposit some tiny seeds of radiation which have a very narrow range of radiation. So it only just affects a 2 millimeter range. So it basically deposits radiation exactly into the area of the liver that we're targeting. And that's seen in this slide here. So we it's all done with interventional radiology, and our radiologists would help us with this, where they basically get into the hepatic artery. There's the tumour that we're trying to block off, and deposit some of these beads into that. So not only are you starving the blood supply to this, but just before you start the supply, you drop off some radiation beads in there, and that will hopefully target the lesion with radiation. Now, there are other techniques which I'm not talking about today, where we can do the same principle and the same process, but we actually use chemotherapy instead of radiotherapy. And again, it's a case-by-case basis that those decisions are made. And again, they'd be discussed at our multidisciplinary meeting, and together with the input from all the players, a decision would be made as to how best to treat that. This is just a slide of what a liver looks like with this is a cross-section through the liver, and all of these black patches are areas where there have been metastases or deposits of tumour. And this is one of the patients that were treated at the SAN, where after having SIR-spheres, you don't need to be an oncologist to see that there's quite a dramatic difference between what those scans look like. Now again, it's an important tool, and we use that together with a number of other options. Again, only relevant for certain situations, and it would be impossible to talk about it on a case-by-case basis here. You'd need all the information about what a patient's situation is like to be able to do that, and that's what the oncologist would do in their consultation. So as you can see, it is a very dynamic and active field, and as oncologists and doctors in this space, it is essential to keep up to date. You'll be pleased to know that it's very easy for us today, because there are a number of sources that we can go to that provide us with daily up-to-dates on new cancer treatments. So we go to these resources regularly. I would like to reassure you that there is not a single oncologist in this country that would look at the Daily Telegraph's listings of new cancer treatments. So when you read an article in the Daily Telegraph of the newest cancer treatment, or Women's Day, or Current Affair, I promise you we would not use that as our reliable resource. All that does to us actually is just add an extra hour to our day, because patients want to find out about this new treatment that some lady had on Today Tonight. So in summary, I think it's clear that we have had significant improvements both in palliation and in survival. The take-home message is heterogeneity, heterogeneity. Everyone's disease is different and it needs to be assessed on its merits. There are many more research questions. These are all exciting agents, but exactly how we use them and trying to better understand which patient is best served by which treatment is still an area of evolving research. How we integrate all of these agents is important, what we can do to optimize the efficacy, and at the same time we want to be minimizing the side effects that our patients are experiencing from this. And this is a way now that we can actually start individualizing patients' treatments. Just to give a plug for clinical trials, this is the way the barriers get moved. It's through clinical trials from the last few years that these agents are now currently available for us on the PBS. So this is what, in your case, Dave, there's a choice: elective surgery, outpatient medicinal therapy, or whatever's in the box that our lovely Carol is holding. And we're starting to understand a bit more what's in that box, and hopefully we can select the right one. And I'd just like to end off a slide that one of my patients gave me, which you mentioned about the big C. One of my patients gave me this slide saying the big C obviously hasn't heard of the big me. And the patient is a very important player in all of this. And I'd like to finish with that. And I'm taking questions at the end, I think. Questions at the end?